Well, thanks everyone for having me, and thank you for the invitation. And it's nice to see a lot of familiar faces and sort of catch up with everyone. When coming up with a topic for today, I thought something that's relevant to I think most of us or all of us is atrial fibrillation from a cardiac standpoint, since it kind of overlaps with a lot of things. And to be honest, the space has moved very quickly. So there's been a lot of changes over the past few years, a lot of changes to guidelines, some things formally codified, some things in the process. So I figured it'd be kind of worth talking about some of those. So with that being said, I figured we'll kind of get a lay of the land here, set some ground rules. The way the talk will be structured, we'll kind of talk about a little bit of background info. From there, we'll talk about some updates and how we manage AFib, and then specifically, I'll spend a little bit of time focusing on the increased role of catheter ablation for AFib, because there's been a lot of new data and kind of information evolving in that space. And then lastly, some special considerations in how to manage kind of unique populations or patients with some Venn diagrams that overlap in certain ways. So with that being said, most of us know what AFib is. We care about it mostly because of this trifecta where it causes symptoms, heart failure, and stroke. But the other thing we know is that its incidence is increasing over time. So by 2030, it's estimated that about 12 million people will have it, and its contribution to mortality is increasing over time. And I'm assuming everybody will have a copy of these, so I'm not going to spend a lot of time reading slides. I'll just kind of talk through them. But management of AFib comes down to sort of this four-pillar approach. Risk factor management, which is all of the traditional things we think of: hypertension, diabetes, obstructive sleep apnea, alcohol use, et cetera. Anticoagulation, which as we talked about earlier and as Ben mentioned, is kind of a double-edged sword. Like, there's definitely pros and cons to all of it. Thankfully, now we kind of have some alternatives. They're not foolproof, they're not for everyone, but we have some options that we had before, not basically just saying stopping it and hoping for the best. Rate control, which really isn't any different than it's been in the last 40 years. And then rhythm control. Like I said, there's now a lot of evolving space in catheter ablation and some new technologies. So we'll start with the risk factor management. It doesn't have a lot of glitz. It's not as fancy, but it's actually probably the most high yield thing we can do. An ounce of prevention is worth a pound of cure. In this case, we know that diabetes is a risk factor for atrial fibrillation, but to what extent? There's a lot of things that now, over the last couple of years, we've seen data where we know there's a direct linear correlation with the A1C. So it goes 6, 7, 8, 9. The higher the A1C, it is directly proportional to the incidence of AFib and the severity of it, how aggressive it is, how easy it is to management. And frankly, just patients with diabetes were more likely to develop atrial fibrillation. And that's just based on a combination of different mechanisms there. But beyond that, what about obesity? What about food, how we handle these things? I don't know if anyone's Parks and Recs fans. There's a lot of these in here, to give everybody a warning. But there's a few different trials. This is sort of a trio of trials: Legacy, ARREST-AF, CardioFit, which ultimately, if you look at these groups, you see those Kaplan-Meier curves when they split. Basically, people who ate better and worked out more did better and had less AFib. That's really ultimately the point of these trials. But these were sort of guided and sort of managed by physicians as part of sort of a network. More recently, this was literally published, I think, just in the last couple weeks, where this is the active AF trial. Prash Sanders, who's one of the senior authors on this, he's based out of Australia. They actually did a targeted program of basically arrhythmia management, and in this case, the only intervention beyond standard care. They didn't do anything else. They didn't ablate anybody. They just made them exercise more and eat better, and you can tell that the group that basically did those things had a significantly reduced burden of atrial fibrillation. This is purely conservative therapy. This is purely risk factor management. And so, it's one of those things where it's easy to say, oh, let's prescribe your beta blocker, let's prescribe your anticoagulant, but really taking the time to focus on these things, I think, has equal, if not higher yield than, a procedure or any pill we can prescribe. So, we, as part of our AFib clinic, really try to emphasize this, and I'll get to some of that later, but it bears repeating. It's something definitely worth tackling in every visit, just like smoking cessation and every other thing. It's definitely worth talking about. Sleep apnea is something that I think we really underappreciate. 80% of patients with atrial fibrillation will test positive for sleep apnea if you test them. This study actually screened this and found that the traditional questionnaires we use, like the stop bang scores or these other ones, are basically useless. They have zero correlation. Basically, if they have AFib, you should screen them, and you will find that many of them are positive. The reason it's important, if we go to the next slide here, is that patients who were treated with a CPAP who had atrial fibrillation, they had a 43% reduced burden of atrial fibrillation compared to those who didn't. So, we can start antiarrhythmics, we can do catheter ablation, et cetera, but that's like trying to put out a fire while if you're not treating their sleep apnea, someone's pouring kerosene on the other side, right? They're sort of competing interests. So it's really worth trying to treat this. Uncontrolled sleep apnea, it overlaps with every one of our fields. It increases insulin resistance, makes diabetes harder to control, obesity, lowers testosterone, it increases your chance of AFib, pulmonary hypertension. It's a very high yield intervention for a very low effort sort of process. So it's definitely worth addressing it and treating it. Alcohol. There's no good amount of alcohol. There used to be maybe a glass of wine with dinner's okay, all this. There's been some no, like it's pretty clear now. There's no good amount of alcohol, but you got to die of something, right? So if you enjoy your bourbon, but know that it absolutely contributes to atrial fibrillation, but all things in moderation. This study basically was a smaller one. There's actually been a much larger one since then that was also randomized, and it shows the same thing. It's a pretty linear correlation. So, I tell my patients, is a glass of wine at dinner the reason you're going to have AFib? No. Now, if you're drinking a few per evening or multiple times a week, yeah, maybe. So just one thing to consider as you take this blanket of all the different risk factors that we can sort of control. Dementia. This is something that's been a little more recent. There's been a couple trials. Most of the work's done by Jared Bunch out of Intermountain. They're kind of based out of Utah and some of that area. And they basically took folks with carotid disease, without carotid disease, so they kind of accounted for that. There was a separate study, this is the one I'm showing here, where basically maintaining rhythm control made a difference in the incidence of dementia in these patients, and specifically they looked at catheter ablation, and again, whether it's antiarrhythmics or an ablation strategy, at the end of the day, minimizing atrial fibrillation reduces dementia. And the mechanism that's proposed on this, they did cranial imaging on all these folks, they found far less or far lower amounts of kind of these microemboli or like cerebral ischemia, because even if you're in anticoagulation, being in atrial fibrillation, you're kind of generating microemboli, and you also have hypoperfusion to those tissues, and then again that's exacerbated if you already have some degree of stenosis in the blood supply to the brain. So all of these things sort of make a difference. Again, all just to imply that treating these risk factors, either directly or rhythm control helps modify these risk factors in kind of a two-way street. Does that make sense so far? Pretty good. Okay. So with that, we'll get into stroke prevention. Everybody's familiar with the CHADS-2-VASc score at this point. These are the risk factors. The more points you have, the more likely you are to have a stroke. And so we calculate these points. And like Ben mentioned, there's the use MD-Calc, right? So it's like a ton of calculators out there. They're very convenient. This is the website version of it. But what do you do for folks who have coronary disease and atrial fibrillation because they need antiplatelets and antithrombotics, and they're just asking to bleed everywhere? We used to do triple therapy, so you would just put them on all three, and then they'd all come back with bleeding. And turns out, don't have to do that. We basically drop the aspirin in everybody. If you get a stent, fine, you get to keep the aspirin for a month, and then we drop it anyway. So really, you should, unless it's a really fresh stent, no one should ever be on more than two things, period, ever. Like that's the general rule now, and that's codified in the 2019 update to these guidelines. So, and any antiplatelet, whether it's Plavix or clopidogrel or prasugrel, et cetera, and then the anticoagulant of your choice. There was a nice trial that looked at this. This trial has been done with every anticoagulant, so there's one for rivaroxaban, there's one for apixaban, there's one for all these. This is just the apixaban one, but the Augustus trial looked at folks with basically an antiplatelet and warfarin, an antiplatelet and like Eliquis, an antiplatelet and something else, and basically when you combine Eliquis with a P2Y12 inhibitor, which is like Plavix or Effient or Brilinta, et cetera, those patients had less bleeding, fewer hospitalizations, and there was no difference in the number of ischemic events. So it's not like their stents rethrombosed. They didn't have a higher incidence of any of that stuff. So drop the aspirin, 2 agents is enough, basically. But kind of piggybacking on some of the other things that we saw earlier today, in this same trial, and this was thousands, I mean, this is almost like 250,000 patients over the course of this huge registry. 27,395 patients with these agents were treated with antithrombotics. If they found a GI bleed, there was a 20-fold higher incidence of new GI cancers in these patients. If they found a genitourinary bleed, there was a 32-fold higher incidence of new genitourinary cancers. And does that mean that these anticoagulants cause bleeding? No, but they unmask or intensify bleeding that's already pre-existing. And so the general rule of thumb, and I don't think a lot of us do this as much as we should, is that any new gastrointestinal or regenerative urinary bleeding on patients started on new antithrombotics warrants investigation because there's just a high incidence of malignancies at these sites that are caught. So that's something that I think it's sort of brushed under the guidelines, but something that we probably should spend a little more diligence on. So what do we do about all these folks? We've spent a lot of time talking about bleeding. So we talk about risk-benefit of anticoagulation. If you look at the CHAD score, like let's say we have someone who's 76 years old, has hypertension and coronary disease. So their score's 4, but they also have abnormal renal function or hepatic function. They're predisposed, they're already on an antiplatelet as well. And then again, by definition, being 76, they're already above 65. And again, they're already on Plavix. So when you do the math, just calculating their score alone, their bleeding risk already outweighs their stroke or systemic embolism risk. That being said, we would normally still continue most of these people on anticoagulation because most of the time, numbers aside, risk benefit, it's still better to stay on it. A stroke is devastating. But for those who truly can't, who cannot be on anything at all because they've had a previous intracranial hemorrhage or recurrent GI bleeds, or it's something that doesn't even have a target, like we see, like you've probably seen a bunch of like AVMs where there's just no good targets, and every time twice in the hospital with PRBC transfusions. For folks who cannot be on an anticoagulant but still warrant stroke prevention, there's a mechanical solution now called the left atrial appendage occlusion. This diagram's an example of one type of it. It's called a Watchman. It's probably the one you hear about more of. If I had to guess, I would assume everybody's seen marketing on it at some point. I will give you a caveat. Even as an implanter, I will say the marketing makes it seem like it will also like make your coffee in the morning and like do your taxes. In the right person for the right reason, it's worth putting it in, but it's a highly select group of people, like stubbing their toe or not wanting to be on anticoagulation is not it. There are very specific and strict criteria for implant. But for people who do it, this is kind of the general process. We'll get vascular access and kind of make sure everything's in the right place. There's a couple different ways to do it. You can do it via transesophageal echo or intracardiac echo. This is intracardiac echo, kind of taking a look at our structures. That's the intraatrial septum. That's our sheath going across, wires over. That's the left atrial appendage, that windsock looking thing. And so we're trying to get it in position. We maneuver the catheter into the left atrium. And what you're seeing here now, that's the tube. We kind of wiggle a pigtail wire into that thing, rail the tube over it to get in there. And then basically we unsheath the device and it sort of expands into place. So we sort of size it ahead of time. The right size is really important because if it's the wrong size, it will embolize, and that's a bad day. Nobody wants to go back after anything, especially because it probably won't be where you left it. I've never had that happen to me. I don't plan to have it happen to me. But once it's in there, we give it a nice little tug to make sure it's stuck in place. You see that tug, that makes you feel pretty good about it being there. Check to make sure there's no leaks around it. If it doesn't fit, you need to move it, but then we let it go in place, and that's what it looks like. It's, I guess, a strawberry-looking shape. And you can kind of see it down in the bottom in there. So that's ultimately how it works. Again, keep in mind, this is a focal solution for a systemic problem, and so it's not perfect. I think we attribute 93 to 95% of cardioembolic disease and AFib to the left atrial appendage, but that other 5 to 8%, I mean, who knows where that comes from? This probably won't fix that. But compared to just stopping anticoagulation and hoping for the best, it's the next best thing, and that's how I explain it to patients. It is non-inferior to anticoagulation. It's not better. It's just not worse. So, but for the right person, it's huge. It's life-changing. So does that make sense so far as the stroke prevention? Okay. So rate control, honestly, nothing's really changed. The only thing I'd kind of take a minute to mention is we see digoxin is listed there. A lot of folks still use digoxin as an antiarrhythmic. It's rate control. Treat it like a beta blocker, treat it like a calcium channel blocker. That's all it's good for. In the right person, it has great utility, but I would think twice about who we use it in just because it has a lot of limitations, but it's very useful in an inpatient setting if their renal function's preserved. Rhythm control. So this is where there's been some adjustments. So let's focus a little bit about the different changes here. From a drug standpoint, not really a lot of new changes. We still have class 1C drugs, which are sodium channel blockers. That's flecainide and propafenone. And then we have class 3 agents, which are largely potassium channel blockers. That's dronedarone or Multac, sotalol, dofetilide, which Ticasin is the name for, and then amiodarone, which is very effective, but has a lot of side effects and long-term toxicities, so we try not to use it if we don't have to. Not a lot of changes here. They're really just limited based on their convenience, whether their kidneys work, whether their livers work, and whether they can tolerate the side effects. But with those, catheter ablation is now playing a larger role. The timing is really everything. Getting people in early makes a huge difference because you're trying to salvage what's there, and you alter the course of the disease by intervening early, so the best outcomes come with early intervention. We kind of reserved ablation for people who fail a drug. You would try a medicine because it's limited danger, maybe side effects, but if they failed a medicine, then you would tee them up for ablation. Now there's some more indications, and more recently there's data that basically shows, turns out ablation's probably superior in most ways, even up front. Now granted, I haven't shifted my practice to that completely, but I think you'll see with the next iteration of the guidelines, they'll probably be more liberal with the ablation indications. But what's the rationale behind ablation? So basically the pulmonary veins, so if you look from the back of the heart here, you see this kind of muscle sleeves crisscrossing and wrapping all around it. Those veins are what trigger these sort of abnormal signals that are labeled with an asterisk. So they're kind of nice, normal beat, and then all the squigglies, right, AFib starts. So those veins are what are triggering these abnormal rhythms. So I tell patients we can't cure AFib. That's not what we do. We're just trying to smother it. So whether you're smothering it pharmaceutically with drugs or whether you're smothering it mechanically by altering or walling off where the signals are coming from, you're trying to achieve the same thing. It's just that one's probably better. So what we do with an ablation here, you can see, I'm in the left atrium, that little 5 pentaspline catheter. We're creating a voltage map of the heart and going into the pulmonary veins and left atrial appendage. So once we get across, this is time lapse, but we basically make a map of the inside. So we're trying to get geometry, trying to see what it looks like, but we're also trying to see where is the electricity coming from, where is it not coming from, what works, what doesn't. This is like our Bob Ross moment where these pulmonary veins are our secret. We paint happy trees. But after we get these maps, ultimately what we try to do from there is then isolate the veins. So we kind of burn rings around each pair of veins. And so you can see here, this person has an atrial flutter that we ablated. And on the right side of the heart, this is the right atrium, this kind of signal wraps around in a circle, so we burn a line through it. But it passively activates the left atrium, so it wraps around, comes up, and then this you can see is just going from start to finish. But see these red dots here? Those little skittles are our burns, and that's kind of where we isolate the veins. So the whole point is those things are firing, but if you've created a barrier, like digging a moat or a trench around a castle or like a fire break, if it can't communicate electrically with the rest of the heart, it can't drive it anymore. And so doesn't mean the veins aren't firing. That's why we don't cure it. We just make it irrelevant. So, but that's typically the general process for that. There's a couple different ways to do this now. Most of the methods are some form of thermal energy. So cryo ablation is freezing it, and radiofrequency ablation is basically a microwave on the end of a stick. This study was called Fire and Ice. Cardiologists are very fond of their trial names. It comes with the territory. But ultimately, they're equivalent. They're good for different things. Some have a slightly more or less risk of one thing versus another. But at the end of the day, they're pretty equivalent in terms of their efficacy. I personally use radiofrequency most of the time because it gives you flexibility. This is a case of a perimitral flutter, and what that means is, here's the left atrium again, and you see this kind of patchy sort of color here. Everybody appreciate that tissue. Purple is normal, red is no voltage, and everything else in between is scar, various degrees of it. So this person already has a bunch of scar here, a little bit on the back wall, but not a ton. But that scar is where there's caused an area of slowdown here, so you can see these kind of weather pattern things going through, and the propagation map, which is where the circuit is going, that's the electrical activation in the moment. So once it wraps back around, we can probably all appreciate, see how it kind of wraps around here, and then it kind of slows down and then breaks out there. It's spinning around the mitral valve, so it's basically going around in a circle like this, and that's their flutter. So it's because the scar has created this channel for it to go through. So what we do is basically burn a line through it. And by occluding that, basically if you eliminate the circuit, no more flutter, and that's kind of the idea. So which technology we use and how aggressive we are about ablating kind of depends on what they have. If they come in with a flutter, you just need to go burn it because drugs don't do well for that. The best way to think of it is if you have 300 cars, like the atrium fires about 300 beats a minute, trying to get onto the highway through a single on-ramp, which is your AV node, most of that traffic is not going to make it. And the stuff that does is very irregular, which is why AFib is very irregular. It's basically the atrial firing and the AV nodes basically wanky-bocking, right? But with flutter, it's kind of like those on-ramps where they stagger every other car coming in. Everybody know what I'm talking about, where they alternate the lights. The whole point of those is that you never really slow down that much, and that's what flutter does. That's why it's always 2-to-1, 4-to-1. It's very regular. I mean, you can have some variability, but for the most part, it never really slows down. So drugs don't do well for flutter, so you need to just sort of interrupt the circuit. You need to take the highway out. So that's kind of how we choose how conservative or aggressive we are with some of these things. So with all that being said, does it work? I have more curves for you. So I cut out a few of the other studies because I feel like they're not as relevant now, they're just history. But these are the more recent ones. The Circa dose study basically enrolled 346 patients, randomized them. They got both RF or cryo. These people all had loop recorders in place, so they were actively monitored the entire time. And ultimately at a year, there was a huge burden of them. About 3/4 had freedom from any symptomatic arrhythmia, and the AF burden overall was reduced by 99%. And again, I tell patients, success isn't I have AFib, now I don't. Success is I'm in AFib this much of the time, it bothers me this much, these are the symptoms it's causing, now that's all this much, and this much. And that's ultimately what these studies show. The Cabana trial was really big recently, and you'll kind of see these curves reproduced all the time. Every study looks like this for AF ablation. Basically, catheter ablation is better than drugs. This was a larger study, 2,000 patients, no difference in mortality. And ablation, basically, they had reduced AFib after the blanking period, which is 90 days after an ablation. They had less AFib compared to the drug arm, and there was fewer hospitalizations in the ablation arm compared to the drug arm. So right now, as of the most recent guidelines, which are still several years old, they still recommend ablation if you fail a drug, or it's two-way to go directly if you're paroxysmal AFib, meaning it comes and goes. If you're persistent AFib, meaning you stay in it until we do something about it, like cardioverting you, shocking you back to normal, or trying a drug or something, it's very reasonable to proceed directly because their AFib's already pretty aggressive. And again, you're trying to restore a normal rhythm and save what's there. Because the more you stay in AFib, the more you end up with those atria that look scarred, where you've got all those kind of parameters, the kind of different colors and all that sort of stuff. So, and if you're long-standing persistent, if it's more than a year, they say you can consider it. I would think twice. I will basically load someone with the drug and try cardioverting them back to normal and see if they hold. If they hold, if they demonstrate any ability to maintain a normal rhythm, even for a few days or a week, then I think it's worth being aggressive in ablating those folks. But if they don't, then it's unlikely that an ablation is going to offer them any long-term solution, and I won't expose them to the procedural risk then. A rate control strategy is probably best. So all of the previous studies had compared ablation to antiarrhythmic drugs after patients had failed drugs. But what about randomizing them up front? So more recently, there was 2 trials, the early AF study and the stop AF study, where they basically randomized patients up front. They said, new onset AFib, boom, you get a drug, you go straight to ablation. And basically the ablation arm was still superior. It basically mirrored the original data. And so now that goes from, reserving it for people who fail a drug to, maybe we should do it up front. Seems a little aggressive. I think there's still some risk benefits to be had there. But the point is that the data is pretty clear. There's multiple studies now that sort of kind of mirror this and show this. And then looking back at it, actually, so if you look at these studies, there's one called EastNet, which I didn't include in here. That was around the same time frame. Progressive AF was now a 3-year follow-up study on those people, and those findings were still durable even 3 years after the ablation compared to drugs. So the point is that it's a durable change, and it alters the course of the disease because you prevent them from just smoldering in their pathology over that time frame. What about some weird populations or specific scenarios? So AFib and heart failure, this is, they kind of often present together. A lot of patients, most of the time they're diagnosed in extremis. They show up short of breath, hypoxic, their volume overloaded, they're in atrial fibrillation with rapid ventricular response. You're not sure if the AFib caused their heart failure or if they're in AFib because they came in volume overloaded and it basically decompensated them. And the truth is, we're not going to know, and it's probably a little bit of both. You just need to address them both. But there was trials that looked at this. CASTLE-AF is a trial that actually showed these are all patients with an EF below 35%, and the primary endpoint was basically death or hospitalization. And there was actually a mortality difference. And if you aggressively control the atrial fibrillation in patients with heart failure, there's actually a survival benefit. Now again, people with preserved EF, it's largely for symptoms, okay? This is quality of life, not quantity of life. Although the more recent data even shows that, EastNet showed that with rhythm control now, we used to talk about AFFIRM, which was rate versus rhythm control, but that trial was basically amiodarone or sotalol, and we only had warfarin. Catheter ablation wasn't on the menu then. And so there's a lot of moving pieces, but the target's changed. Camera MRI is another study where they scanned every single one of these people, and basically the ablation group had more than 58% of the patients who actually normalized their EF compared to the rate control alone arm. And again, the EF improved generally by 18%. So again, ablation superior to drugs in these people in terms of trying to control their AFib and improving their heart function. And then long-term data on that camera MRI study, again, this is basically a couple years later, and they follow these people out to 4 years. That change is still durable to some extent. Now, it's important to note that even the rate control people did improve over time, but not nearly to the same extent that the rhythm control folks did. So what about Tachy-Brady syndrome? So Tachy-Brady syndrome is exactly what it sounds like. It's fast, slow syndrome. People who have symptomatic atrial fibrillation, heart rates in the 160s, 180s, 200s, they need medical therapy to control the fast stuff, but then they have a conversion pause and they end up having syncopal event because they pause for 8 seconds, or once they convert to normal, they're just profoundly bradycardic with heart rates in the 20s and 30s. So you need drugs to treat the fast stuff, but you need a pacemaker to protect from the slow stuff. And people do that all the time, we still do that, but in some folks it's close enough that if you can control the AFib and without an implant, then what we'll try is we'll try ablating first and see if we can avoid the pacemaker altogether. And in about 65 to almost 70% of the cases, it works. And so on average, we don't know if it's just because you're controlling the pathology or if it's because when you're ablating the veins, you do partially ablate your parasympathetic ganglia. Everybody comes out of an AFib ablation with a slightly higher resting heart rate. And so for multiple reasons, many patients are able to avoid a pacemaker. But for those who absolutely can't, let's say it's someone with permanent AFib, we have other options. So if they only need ventricular pacing, meaning they don't need a 2-wire device, they don't need any of that stuff, and you don't want to worry about the can or infections, or especially in some older folks, we actually have leadless pacemakers now. So this little thing, that's actual size. That is called, this brand is called a Micra, Medtronic makes it, but we go through the groin actually and kind of curve it into the heart and sort of hook it into the trabecula in the RV and just kind of deposit it there. Battery life is about 12 years, everything's self-contained. And so there's no generator, there's no wires, it's all trapped in that little bullet. And so for some patients, it's a great option. Again, not for everyone, right person, right time, right place. But before we didn't have a lot of options, or you were stuck with a certain kind of device. Now we have various options for different people for the right reasons. So with all that being said, we talked about rhythm control and the increasing role of catheter ablation. It's still a procedure. Is it safe? Is it worth doing? What risks and benefits are we exposing everybody to? Well, ultimately, we've gotten safer with it. This is a trial we did within Ascension, and the standard for a long time was everybody got a Foley, everybody got a bladder catheter, just like any other surgery. We've gotten good enough at them and fast enough at them that we wondered, does everybody really need one? And we think they do more harm than good, so we did the trial. We did a randomized trial showing that you actually don't need it, and that there's actually an increased signal for harm, largely driven by men, prostate issues, urethral issues, et cetera. But basically, bladder catheters aren't necessary because we're fast enough. What about pericarditis? It occurs in about 1 in 10 people after ablation because you're actively burning or freezing, you're causing thermal injury, there's inflammation of the heart. We used to just wait, give everybody colchicine afterward and hope for the best. It accounts for about 11% of 30-day readmissions admissions within 30 days after ablation. This is another trial. We just got this published in JACC EP last week, where we did an empiric therapy with colchicine versus the standard of care, which is to just wait and see. And we kind of thought it was going to work. Turns out it doesn't make a lick of difference. Not only does it not help in preventing pericarditis, it actually has about a 34% higher incidence of gastrointestinal side effects in the colchicine arm. So before there was heterogeneity in practice, but this will probably change the guidelines to say, we just shouldn't do that empirically. Reserve it for people who need it if they can present with symptoms. Durability and timing, we now have techniques called high power short duration ablation. We ablate at higher wattage using steerable sheaths in point-by-point fashion. This has resulted in shorter procedure times, less left atrial dwell times, and basically better success, because if your catheter's stable, you're getting a better burn versus if it's flopping around all day. And so all of these small adjustments add up. It's kind of, I don't know if you guys have read that book, Atomic Gains, where all these little incremental changes sort of amount to sort of a whole that's greater than the sum of its parts. That's basically what this is. Same day discharge, I would say more than 95% of our patients, at least at Sacred, go home on the same day after ablation. We've gotten fast enough at them and safe enough, especially with vascular access closure, intracardiac echo, things like that, that really the reasons I keep them now are if they are coming from far away. Like we have folks who come from different parts of the other states or things like that. Our threshold to keep someone's low, but for the most part, there's no reason why most people can't go home the same day. So what's really new? This is all updates, but now what's the new hotness? Pulse field ablation is coming out. The technology has been around for many, many years in other fields, but while we mentioned that radiofrequency and cryo were thermal energies, this is a non-thermal energy. So this is one example. This is ferropulses. Wire into the vein. It creates a dielectric field which basically electrically perforates the cells, but based on the voltage that you give it and how you deliver those pulses with the way the biphasic waveform, et cetera, you can actually selectively target myocardial tissue while sparing phrenic nerve, esophagus, other things, which are usually the rate-limiting steps in ablation, is basically can you burn without collateral damage. And so this, in the atria at least, so far the data is pretty good. This will be a game changer. This is, you will see in the next 5 years, our threshold to do things and how safely we can do them, at least for AFib specifically, will change dramatically. It's not a silver bullet. It won't fix everything. There's still, like for example, people try to use it for flutter lines, but it causes RCA, coronary vascular spasm, and it resolves with nitro, but you're not going to do a flutter line with it probably. So, but for that sort of thing, it's very effective. And then on the drug side, we talked about bleeding a lot. We talked about antiplatelets, antithrombotics. Rivaroxaban, Eliquis, they're all factor 10A inhibitors. But now we have factor 11 inhibitors in trials. We're going to be one of the study sites for it. I think we start in a month or two, where these work upstream. So they still prevent thrombus formation, but they don't hit the common pathway of factor 10 and below, which also affects factor 2, which is the generation of prothrombin and thrombin. So in this case, you still prevent thrombus without affecting hemostasis at a skin level. And so this, in phase 1 and phase 2 trials, has been very promising. If this pans out, this is having your cake and eating it too. And this would even potentially make left atrial appendage occlusion less viable and things like that. So this is, if this works, it's a big deal. And so we're very excited to see how that shakes out. Time will tell. Honestly, I think it'll make a big difference really for a lot of us. And then lastly, I just want to spend a minute on the AFib clinic. You probably have heard these terms and everything. These are specially designed to provide extremely tailored care. AFib is not a one-size-fits-all diagnosis. There's a reason that it's got such a high propensity. There's a reason you'll probably see AFib clinics. It's kind of a center of excellence sort of thing. There's criteria to have it. But they let us focus on a lot of these sort of quality metrics like remote monitoring. We actually do sleep apnea testing through our AFib clinic directly. We do telehealth. We have multi-platform integration in our EMRs. We use a third party for that. And then we do, again, like you've seen, we do research and try to actually inform the process itself and sort of change it from the inside. But AFib clinics have been shown in multiple studies to reduce time to therapy, to reduce mortality. It basically reduces ED visits. It's, when you have something that's available to patients as a resource, it's a big deal. That's when we first started. We now have 3 nurse practitioners and 2 nurses, and we all rotate through it now. We even generate our own sort of personalized treatment card. So each patient, every visit they come in, we mark, this is what you have in each category, this is what you go home with. So they know this is what I'm on when I leave, this is what I come back with. And it's kind of tailored, and by the time they get through a couple visits, now they know it by heart. But it's a way to make sure that they know exactly what they're taking and why they're taking it relevant to this specific diagnosis. And then this is an example of when we first started our sleep apnea testing. You can see that this is a cloud-based solution, but you could see we were able to get everybody tested, but then there was this, and again, 80% of them are positive, but then getting patients set up, we ran into insurance issues because it was like a third party that's run out of some other places. So now we're moving it internally. Zoll owns NMR now, and so now it should have better coverage in Florida and stuff. But this is like sort of the first steps of getting that started. And then this is kind of data that we ran. This is purely like last minute. These are like a list of some of our pacemakers, defibrillators, just devices across the top by brand. But we basically ran that and just did a cross-reference for every drug they're on to see how many of them, what's their anticoagulation strategy. And you can see at a glance, just running our own internal data, that we have a ton of people on Eliquis, we have a handful on Xarelto, a bunch on warfarin, Pradaxa apparently nobody likes. And then we have most of those individual ones, like, and again, these aren't meant for you to read individually, or basically they're not on something for some reason. So these are patients who you ask, should they be on a factor 11 inhibitor? Should they be considered for a Watchman? Should we just not put anything in them? What's our risk benefit? So at a glance, you can actually now, if you have this aggregate within an AFib clinic or some way to look at this data, you can sort of do population management, population health. We talk about digital health all the time, but that's how you do this stuff, is by harnessing the stuff we have. So ultimately, AFib is an irregular rhythm. We care about it because it causes symptoms, heart failure, stroke. Management involves a 4-pillar strategy of risk factor modification, rate control, rhythm control, stroke prevention. Catheter ablation recently has a much higher or increasing role in the management, partially because we're better at it, partially because there's just data to support it, and partially because it allows us to eliminate or minimize a lot of other adverse issues. For patients who can't be on long-term stroke prevention with the blood thinner, left atrial appendage closure is now a reasonable alternative in the right patients. And again, there are some pretty new technologies, both on the ablation side and on the drug side, that will hopefully optimize a lot of this. And lastly, AFib clinics make a huge difference in the management of these patients, and if there is one near you, I'd encourage you to sort of get them plugged in with that. But that's pretty much it.
Thank you for that presentation. Quick question on the studies that you were talking about, where I was looking at medical management versus ablations. Were any of the secondary endpoints strokes, and how
Yeah, in fact, it's a good question. So EastNet, which is probably the first one of these, and then those other two that came after, they actually looked at the endpoints, and there was no difference in terms of complications, strokes, or specifically in terms of ablation versus drugs. However, there was a mortality benefit for rhythm control versus rate control, and what they found was that it was largely driven by basically, it's a composite endpoint of cardiovascular endpoints, which included actually like MI and stroke and other things. So it's like, now, to be honest with you, like, why would treating someone's AFib and maintaining normal rhythm prevent occlusive coronary artery disease in the future? I don't know if I have a clean answer directly, but it may be directly related to the risk factors, or maybe it's just more consistent follow-up. Who knows, like, what extra things are in there? But the point is, we know there was a reduced mortality, and specifically, even when you accounted for individual things within that composite endpoint, it actually made a difference in those things, including stroke, MI, et cetera. So.
I just had a really quick comment. That card that you showed, I really love, because, and I hope that you recommend that your patients take it to their primary care too, because like that discussion you were having with GI earlier, what is the real risk and what is the real disease, and why does this guy have him on, this medicine, would be really helpful for us to all just have a really quick read. We can do all the research too, but that's a great idea, and I think too many patients have no idea why they're doing what they're doing and can't relay it to us. So those little kind of ideas are really helpful for us to help our patients and know how much or what they should be on too.
Yeah, absolutely. Thank you.
Nobody?
Bueller.
He was too thorough.
Okay. I think we're good.
Okay, that was a great lecture. Thank you very much.